Sorry about that. It snapped off. Computers do funny things, don't they? So the disease caused by Campylobacter, you have an incubation period of about 1 to 3 days. The early symptoms, the onset is quite abrupt. You have abdominal pain and diarrhea. Some cases you have prodromal fever. So before this onset, you have a fever about 30% of the cases. Maybe generalized aches, dizziness, delirium. Nausea and vomiting, very common. You have cramping, periumbilical abdominal pain, diarrhea. Usually lasts about 7 days. Diarrhea may be bloody at times. So this disease is the disease that causes the most common bacterial GI infections on college campuses. Complications, there's co-infection with HIV, that's more common than you think. Also a pseudo appendicitis. So you'll have all the symptoms of appendicitis, but then when the appendix is surgically removed, there are no organisms there. And then also colitis as well. Organism tends to run its course, tends to usually not require treatment. Complications are rare, but if they do occur, you may have cholecystitis, so infection of the bile duct and the gallbladder. Peritonitis, that's more the case on patients who have the ambulatory peritoneal dialysis. Sometimes there's a rash. That's pretty rare, but it happens. Septic pseudoaneurysm, pericarditis, and myocarditis, those are some potential side effects. So let's talk now about another gastroenteritis. It's caused by Yersinia, but not Yersinia pestis, Yersinia entercolitica. So this gets transferred by the fecal-oral route. And most commonly it's associated with pork consumption. So usually undercooked, raw pork have been responsible for a fair number of your outbreaks. So the organism, it goes to the gut. And then it can cross the gut wall, and it takes up residence in the lymph nodes. Usually the mesenteric lymph nodes. So the bacterium can withstand the stomach acid because it has a urease. That urease will take urea and convert it into carbon dioxide and ammonium. And this buffers the acid of the stomach. There's another organism that uses this trick as well. So the organism can withstand white blood cells just like its cousin, Yersinia pestis. And the an immune response to it can cross-react with this, and it can cause a reactive arthritis. So you get diarrhea and abdominal pain, nausea, vomiting, and you also get fever. The diarrhea can last 12 to 22 days. Bloody diarrhea is more often seen in children. Sepsis is not common in adults. It's seen more often in infants and the immunocompromised. And then the organism usually will continue to shed organisms. You may shed for 17 to 116 days. You can also mimic, so you can get also with this a pseudo appendicitis. And the reactive arthritis will affect multiple joints. This organism is hard to culture, so cultures will tend to be negative. So cultures are not a lot of help with this. If you gram stain stool specimens, you'll see an organism, and that organism may kind of look like a safety pin. There are good serological tests. Polymerase chain has not been widely used. So treatment, definitely you're going to need a hydration and nutritional support. And then the drugs of choice are usually doxycycline. You don't want to use doxycycline in children. In children, you'll use fluoroquinolones. And doxycycline, of course, it'll be 100 mgs. BID, depending on how sick the patient is, usually 7 to 10 days. You may need to treat for longer, may need to treat for 14. Fluoroquinolones, if it's Levofloxacin, usually 750 mg, QD, usually for 5 days. If it's moxifloxacin, it's 400 mg, QD, also for 5 days. And that is Yersinia entercolitica. Now I'd like to talk about a very interesting organism called Helicobacter pylori. So here's a picture of Helicobacter pylori. You see it has a tuft of flagella at one end. Very highly motile organism. It's a little bit spiral shaped. So it's positive for catalase, oxidase, urease. Can survive for long periods of time in drinking water or feces. It can transition to coccoid forms, and the coccoid forms seem to be a resting resistant form, but it does not make spores. This is a microaerophil, and you have these 2 to 7 flagella at the end. So this organism is the most common bacterium in people. It's found in people all around the globe. Humans first had it clearly when they emerged from Africa some 60,000 years ago. Half the human population has it, but doesn't know it. Children usually acquire it before the age of 10. Prevalence peaks at about 80% at age 50. It's acquired from contaminated food, water, animals, maybe even from person-to-person contact. It uses its very powerful urease to neutralize gastric acid, remember. So urea is a molecule that looks like this. That's urea. And so the enzyme urease is going to break this down. And you're going to get carbon dioxide, and you're going to get and this equation is not at all balanced, but I'm not going to take the time to balance it right now. All right, so this particular organism, because it uses this to neutralize stomach acid, it also has a urea channel that can regulate its own intracellular pH, and it's able to attach to gastric epithelia very effectively. It also has enzymes that degrade mucus, so it can get to the gastric epithelia. And there's a nice picture here of the organism attaching essentially to the gastric epithelia. You can see this dark line here of cells. Those are Helicobacter pylori attaching to the surface of gastric gland cells. And here is an example of Helicobacter pylori nicely attaching. You can see it induces the formation of a little pedestal upon which this will attach. So it binds very tightly to the gastric epithelium. So highly motile, resists stomach acid, and it attaches tightly to gastric epithelium. Now, Helicobacter pylori has several disease-causing tricks up its sleeve. So first of all, it's the urease I talked about. And proteins, these are other adhesins. So it has these adhesins. It has lipopolysaccharide that can induce inflammation. The motility helps it colonize the mucosa. It can burrow through this thick layer of mucus. It makes a toxin called a vacuolating toxin, VAC-A. The vacuolating toxin damages gastric mucosa. The gastric mucosa now leak nutrients to the organism that helps feed it. Can also break down mucus, also makes proteases, lipases. Those can also potentiate greater host cell damage and feeding of the organism and invasion into the gastric mucosa. It then has a type 4 secretion machinery. We've seen that before. This little injector system injects molecules into the cell that causes it to change its behavior. And that change in behavior helps this cell survive while attached to the gastric mucosa. So adhesins, urease, toxins, enzymes, type 4 secretory system, and flagella. All important for the way this organism causes disease. Oh, this organism too makes lots of catalase. So if white blood cells try to kill it with peroxide, that peroxide gets converted to essentially to hydrogen peroxide gets converted to water and molecular oxygen. Now, this organism can cause a chronic gastritis, and it's been shown to cause peptic ulcer disease. It was thought for years that peptic ulcer disease was due to your diet or worrying or something like that. No, turns out it's these bacteria. You can see them here colonizing a gastric crypt. So this leads to chronic inflammation of the gastric epithelium, and this chronic inflammation has been linked with a higher risk of gastric cancer. It's also been linked with a higher risk of the mucosal associated lymphoid tissue lymphoma, and also because this organism is very good at sequestering iron, it can cause an iron deficiency anemia. So test for Helicobacter pylori if you have an unexplained iron deficiency. Also test for it if they have this dyspepsia that just won't go away. And a test for this organism, there are some very good and some of them are very easy tests to conduct. So because the organism breaks down urea, there's a urea breath test. That's a test you can conduct at the bench, the bedside. There's a stool antigen test. This test is a bit more expensive than, well, this one, equipment. Need the right equipment for this one. Not every test essentially is equipped for this. There's a biopsy of the stomach urea test that can be conducted in labs pretty routinely. Of course, endoscopy, the organism should come from a culture of the biopsies you take from an EGD. And then stool antigen is a pretty good test. If the patient is positive for Helicobacter pylori, there is a triple, quadruple treatment that you can do. This is the way you treat Helicobacter pylori. So you're going to use essentially bismuth sulfate, which is found in Pepto-Bismol. So you use bismuth sulfate, and you also use a proton pump inhibitor. That's going to help heal any of the damage in your stomach. This coats the stomach, prevents the organism from damaging it further. Then to kill the organism, you're going to use usually metronidazole, and you'll combine that usually with either clarithromycin. So that's your quadruple treatment: bismuth sulfate, PPI, and then these two antibiotics. Or you may combine metronidazole with amoxicillin. So that's your quadruple treatment. That's a standard fare treatment. If metronidazole doesn't work, you can substitute these for levofloxacin. That would be your triple treatment: levofloxacin, and then these two items, the PPI and the bismuth sulfate. So triple or quadruple treatment, and treatment is usually for about 2 weeks. And that is Helicobacter pylori. All right, let's talk about noroviruses. So these cause the so-called stomach flus, which are not flus at all. It's a viral gastroenteritis. So norovirus, there's lots of groups of norovirus. So groups 1 and 2 and 4 are the ones that cause disease in humans. And I am pretty sure just about all of you have probably had norovirus. So these are positive strand RNA viruses. They're part of the Colica viruses. They're not enveloped. They have an icosahedral capsid. They're quite small, these viruses. They infect the small intestine. They cause inflammation of the mucosa. You get it from the fecal oral route. So aggressive hand washing can definitely quell norovirus outbreaks. So if stool ends up in the water supply and that water irrigates agricultural fields, flies can pass it too. So can fingers touching contaminated surfaces. So the 4 F's: fingers, fields, flies, fluids. And fields. Outbreaks are really common in nursing homes, hospitals, schools, athletic teams, prisons. So there's a 12 to 48 hour incubation period. So this virus works pretty fast. Symptoms last usually 48 to 72 hours. There's a very good RT-PCR test for the virus from stool samples. The treatment is supportive. Antiemetics can control vomiting. There's no vaccine. And by practicing good hand hygiene, you can limit the outbreaks of norovirus. There are other types of viruses that can cause gastroenteritis, and they tend to have symptoms that are pretty indistinguishable from each other. So there's the echoviruses. There's Coxsackie. Viruses. There's the enteroviruses. Oh, in that we could throw hepatitis A. All of these are passed by the fecal oral route. Now, rotavirus, this is a double-stranded RNA virus. This is a major cause of infant mortality. It replicates quickly, produces large numbers of virus that then pass through the gut. There's good ELISA tests for this, immunolinked, immunosorbent assay tests. There are two rotavirus vaccines that are licensed in the U.S. There's the Rototech. So this is 3 doses that you give. Oh, what is it? 2, 4, and 6 months. I believe I have that right. Then there's a Rotarix. That's given in 2 doses. That are 2 and 4 months. I'm pretty sure I have that right. First dose should be given before a child is 15 weeks old, so give it before. There's no injection. You put drops in the mouth. And getting this vaccine widely distributed can really decrease a lot of mortality and morbidity in the developing countries. All right. Our next subject is not very pleasant, but some of you will do international medicine. Some of you will travel to other countries and do medical missions. I hope you do. I hope you take your skills to darker places of the world that need the touch of the gospel and in a very tangible way. I hope you do that. And if you do, you're going to experience amoebic dysentery. So with this, you have the organism is capable of forming a spore. Well, it's actually called a cyst. So, and then it can exist, and it can become a so-called trophozoite. Some people get this and it's completely asymptomatic. If you're not used to it, usually you will have abdominal tenderness, and probably also abdominal pain. And sometimes fevers. So this organism takes up, and you get this, of course, from contaminated water and food and what have you. This is caused by Entamoeba histolytica. However, there are other species that can cause this too. This is in the colon, and it makes this really interesting kind of flask-shaped lesion where the little critter lives. That's kind of what you see in a colonoscopy. There are lots of different potential complications. Those are usually quite rare. There's a very good stool PCR test. Very sensitive. There's serology tests too, but they're not used quite so much. So treatment, of this. The best treatment is metronidazole. So 500 to 750 mgs 3 times a day for 7 to 10 days. That's a treatment of choice. If you have a liver abscess, which is a problem, then you could use tinidazole. That's 2 grams QD. And that's anywhere from 3 to 5 days. Tinidazole. It's a relative of metronidazole, but it's better for treating eukaryotes. If the patient has cysts in their GI tract, these drugs do not affect the cysts. So there are other drugs that are used for cysts. There's a drug called peronomycin. Peronomycin is a non-absorbed aminoglycoside. And you take this for 7 days, 8 to 11 milligrams per kilogram body weight. You take it, of course, PO for 7 days. That will wipe out cysts quite well. And if any of you work in more rural environments, you will see tapeworm infections. Yes, disgusting, aren't they? So the first is Taenia solium, and this is the common tapeworm of pork. You get this by consuming food contaminated with fecal material from infected pigs. And then the eggs hatch inside the stomach, and the embryos will then penetrate. Well, they'll attach at the mucosal surface. Because this organism is normally a pig organism, it's not an organism that humans see. It will penetrate the GI tract and it will form a so-called cysticercus. And it can form this is called cysticercosis. These get in the way. They cause a lot of problems. And you need to usually remove them surgically. But the drug of choice to treat this is called niclosamine. This is rare, but if you get people who do a lot around pigs, you may see this. You'll see this on an X-ray. There's another organism that does a similar sort of thing. It's called Echinococcus. And the host for this is the dog. But if a human eats material contaminated with dog feces, it forms a so-called hydatid. And this disease, therefore, is called hydatid cyst. These will have to be surgically removed. You can regress them using the drug mebendazole. But you also are going to need surgery. And that surgery requires a lot of skill. Blood vessels have to be tied off. The hydatid has to be aspirated and filled with 10% formalin, re-aspirated, then remove, and you're almost never dealing with just one hydatid. Not a very appealing subject. Then there is vampyrolepsis. This is a parasite of insects. Why is that an issue to us? Because insects are eaten by mice. And then the mice, with their feces, may contaminate food if they get into your food. And there's a Hymenalepsis nana, it's called. There's a closely related species called Hymenalepsis diminuata. You find the proglottids in the feces. So you do fecal smear. You can't miss them. They're very, very hard to miss. They've got organs and vigilant organs and what have you. You can't miss them. So treatment is with praziquantel. Praziquantel does a very good job against tapeworms. These can cause B12 deficiencies. Sometimes you get these people who take diet pills from overseas, and those diet pills are filled with tapeworm proglottids. And praziquantel will get rid of those. And finally, there are your nematode infections. So the ones that are important to human medicine, first of all, is Ascaris lumbricoides. The eggs of Ascaris have resistance that is legendary. You get this by eating food contaminated with dirt. The worm is, the eggs are easy to see in fecal smears. The worm is big and tends to move around in the intestinal lumen, and it tends to cause pain. Fortunately, it's very treatable. Mebendazole is a drug of choice. The whipworm, Trichuris, you get this again from consuming things contaminated with dirt, water contaminated with feces. These will make an egg. The egg has this bipolar appearance. It has these little air-filled bits at both ends. You can't miss it. You can't miss it. So this is the so-called whipworm. And this worm is slender, and then it gets fat like this, and so on and so forth. And the slender end inserts into the intestine, and it feeds, and treatment is with mebendazole. Works very well on these critters. Two others I want to talk about. One is hookworm, because hookworm you still get in the U.S. in the South. So this has a complicated life cycle, but the eggs hatch in the soil, and then it becomes a so-called filariform larva, and the filariforms can penetrate skin. And so if you go barefoot on this soil, if you stick your hand in the soil, it'll penetrate the skin, and then they feed in the small intestine. They suck blood. Eggs can be hard to find in the stools. There is a pretty good serological test. But treatment, so there's two of these. There's Necator, and there's Ankylostoma. These are your typical hookworm. There's another one that's similar to these, but it resides in the large intestine, and that's Strongyloides. And this is treated with thiabendazole. And these are treated with mebendazole. And then, finally, there is pinworm. Enterobius vermicularis. Pinworm is a curious little critter. So the organism lives in the colon, and then at night, the gravid female, she emerges on the perineum and she disintegrates. And so she causes perineal itching. And what do? There's all these eggs there, so you itch, and then you put your hand near your face and you reinfect yourself. Now this, besides the perineal irritation, these things cause very little pathology. However, because the eggs get on the bedding, and the eggs are very delicate, they can waft, and you can actually get this through inhalation. So pinworm infections were once popular in laundromats. Now, if a kid itches a lot and is sleeping very poorly, what you can do is you can do a Scotch tape mount Scotch tape mount of the perineum, and you'll see the eggs, and the eggs look like tiny beans, but they have this little seam coming up the middle like that. You can't miss them. And they're usually brownish. And the female will dump anywhere from 5,000 to 16,000 eggs on the perineum. I said the colon. That's not right. It's the ileocecum, which is part of the colon. All right. The ileocecum. And this is very treatable. So the Scotch tape mount is a surefire, yes, you have it. So you treat this with mebendazole. And that works really well. Okay, so those are the, oh, wait. There's one more thing I really need to talk about. Clostridium difficile. So Clostridium difficile causes pseudomembranous colitis. On colonoscopy, the colon will have this yellowish membranous yuck stuck to it. Clostridium difficile is virtually always associated with antibiotic use. There are just no two ways about it. And if you have a hospital where people are being treated with lots of antibiotics, this can get passed around the hospital. In England, they don't allow hospital staff to wear ties because it turns out the ties, as a physician bent over, were getting on the patients, and that's how patients were getting inoculated with Clostridium difficile. So this will cause fever, abdominal cramping, and you might, on radiology, you might have evidence of megacolon with a rather profound increase in white blood cells. So your white blood cell counts might be up to 100,000 per cubic millimeter. This infection is nothing to sneeze at. The biggest culprit is clindamycin. So clindamycin, but others can too. So penicillins, fluoroquinolones, cephalosporins are all associated with Clostridium difficile infections, but clindamycin is probably the biggest offender, shall we say. So the organism makes two toxins, and they're called toxin A and toxin B. These will cause most of the symptoms of the disease. And treatment usually because the organism is a pretty severe anaerobe, like all Clostridia, so treatment, well, diagnosis is usually with a colonoscopy, and then usually some other imaging of the bowel. The organism can be cultured in stools, but you have to use anaerobes. So you have to use a gas pack and so on and so forth. Treatment is usually with metronidazole. There's MIC creep on metronidazole. So oral vancomycin has been shown to be effective. Also, there is an aminoglycoside called fidaxomicin. This is a non-absorbable macrolide that goes through the GI tract and basically kills everything in its sight. So these are kind of your three options for treatment of Clostridium difficile. The fecal transplants, because people discovered that fecal transplants sometimes transplant pathogens, there's less enthusiasm for fecal transplants than there were before. So fecal transplants, folks are not so excited about that anymore. Okay, gang, that's it for the GI tract.